Hello, and welcome to an evidence-based approach to the assessment and diagnosis of congestive heart failure, a video brought to you in conjunction with the UC Davis School of Medicine. In this video, we'll provide a quick overview of the evidence-based physical exam, discuss an evidence-based approach to physical diagnosis and assessment of congestive heart failure, and provide a video of a UC Davis Master Clinical Educator demonstrating high-yield physical exam maneuvers that every UC Davis grad should know and the evidence behind them. Hand washing before and after each physical exam has been well studied and shown to reduce morbidity and mortality in the hospital and the clinical setting. We're all taught the basic tenets of the cardiovascular exam in medical school: inspection, auscultation, and palpation. And while these provide the basis for a complete cardiovascular exam, this video is going to take a slightly different approach. An evidence-based approach to the physical exam begins with a diagnostic question. For example, does this person have chronic anemia? To answer the question, you first estimate a pretest probability, which is essentially your best guess as to how likely you think this patient is to have the pathology in question, based on aspects of their history, presenting symptoms, etc. It's generally expressed as a percentage. Using this as your starting point, you choose an evidence-based physical exam maneuver, which, depending on whether the test is positive or negative, will feed back on your original hypothesis, giving you a new post-test probability, as demonstrated in this figure. For example, if you don't think that your patient is anemic, giving them a pretest probability of 20%, but then you discover conjunctival pallor on exam, that really changes your thinking, giving you a much higher post-test probability. How much a given physical exam maneuver changes your pretest probability depends on the sensitivity and specificity of the test, which in this case is expressed as a function called the likelihood ratio. You can see in the figure how a positive or negative likelihood ratio can affect your pretest probability either a great deal, for example if you have a positive likelihood ratio of 10 or more, or barely at all, for example a likelihood ratio close to 1. So let's see how this approach applies to congestive heart failure. So again, we begin by estimating our pretest probability, which is our best guess as to whether or not this patient has congestive heart failure based on their age, presenting symptoms, past medical history, medications, substance use history, etc. Now, estimating a pretest probability in patients with suspected heart failure has actually been well studied, and there are two things I'd like you to remember. First, where you're seeing the patient will inform your pretest probability before you even lay eyes on them. For example, if you're seeing the patient in your clinic for a regularly scheduled visit versus in the emergency room versus in the ICU, each of those three venues have very different baseline prevalence of heart failure and thus very different pretest probability when you're going to evaluate your patient. Second is just how prevalent systolic heart failure is in the right clinical context. For example, a meta-analysis published in 2005 in JAMA found that the prevalence of systolic heart failure amongst adults presenting to the ED with dyspnea without an immediately obvious other cause was about 50%. So right off the bat, if you see a dyspneic adult in the ED, systolic heart failure is already high up on your differential. Now, I'd like to start by talking about the physical exam maneuver that has the highest positive likelihood ratio, the presence of an S3 gallop. This is a subtle finding on cardiac auscultation that we'll learn more about later in the video, but I'd like to show a diagram right now, just sort of describing what it is. Essentially, you see S3 here. It's a low-pitched, low-amplitude sound that follows S2 that comes from incomplete emptying of the left ventricle during systole, best heard at the apex with the bell of the stethoscope in a quiet room. The mnemonic I like to remember for this is rushing in, which I find to be a little more descriptive than the traditionally taught Kentucky. Here's UC Davis Master Clinical Educator, Dr. Mark Henderson, with more.
So, one of the most important physical findings in detecting heart failure is the presence of the S3. And the best way to find an S3 is to palpate the point of maximal impulse, or the left ventricular apex. Now, before we do any of that, we start with inspection of the precordium, right? So the things we want to look for here are, we want to look for at the sternum to see if there are any abnormal movements of the sternum, like a parasternal heave. You could see that. You can see the right ventricular apex is usually about, at this point, at the fourth left interspace. So I look there. I don't see anything. The left ventricular apex is typically in the fifth interspace. So here, mid-clavicular line, that's where it normally would be. So I look there for abnormal pulsations. I thought I could see his chest move a little bit earlier. Let's see. Sometimes you will see that. Anyway, so the inspection again, the sternum, the left ventricular apex. Some people look in the subxiphoid area for pulsations. I don't see any. So next to palpation, first of all, again, I put my hand on the sternum, and I'm basically feeling for a movement of the sternum. A parasternal heave would occur when, with each beat of the cardiac cycle, I would feel my hand move. So that's a right ventricular or sternal lift, sign of right ventricular enlargement. Sometimes you can also feel an impulse here, again at the RV apex, which is at the left lower sternal border, which I don't. So in terms of finding the LV apex or the PMI, let's start us, usually start in the midclavicular line below the fifth interspace, maybe the sixth interspace. And then I'll usually put my hand, this part of the hand is a sensitive part of the hand in terms of feeling pulsations, so I'll feel around with that part of my hand first to get a sense of where it is. In many individuals, you don't palpate the apex beat in the supine position. I actually do feel his PMI about right here. But a maneuver that we teach that's very useful is the left lateral decubitus position, because when you put the patient in that position, you're bringing the left ventricular apex closer to your hand. So I'm going to have you, David, roll over to the left side. This is that's not all the way over, but sort of depends on what level, what angle is sufficient. Depends on the patient, but I think this is not too uncomfortable. Sometimes I'll put a pillow behind their back if I'm going to take a long time, and then again, this maneuver, it's very obvious that the apex beat comes out. So right where my finger is, I feel a very clear apex beat. So then what I would do is I would actually take out my stethoscope, knowing where that apex beat is, and listen with the bell over the left ventricular apex. So in terms of listening for an S3, some of the two biggest mistakes people make are, one, not finding the apex beat, because the S3 is in a very small location. It's only in about the size of a quarter at most, sometimes a little bigger. So you have to find the apex if you want to hear the S3. So finding the right location and then using the stethoscope properly. Another mistake people make is they press down too hard on this bell, which then tends to diminish the low-pitched sounds, which the S3 is one of. So I use very light pressure. I don't put any pressure on the actual stethoscope. I usually steady it with the tubes, and I'll listen right there. Again, for the presence of the S3, he doesn't have one.
Other than positioning the patient in left lateral decubitus, there are other tricks for locating the point of maximal impulse.
Something I find useful occasionally is to amplify the signal, if you will, by using a Q-tip or a tongue depressor. You'd place the Q-tip on the apex beat and then watch the movement of the Q-tips. I don't know if you can see that, but it's got two bumps on it. When you have a gallop, you'll see a third. You'll see the S3 come right after the second deflection. It'll be very obvious. You can only see two.
Now, I mentioned before that many of these physical exam findings have been very well studied, and the presence of an S3 has prognostic value as well as diagnostic value. It has been independently associated with increased 5-year mortality, increased rate of post-surgical complications, and a higher BNP. I also wanted to take a moment to say that most of the data for these likelihood ratios was taken from the JAMA Rational Clinical Examination, which I found did the most rigorous analysis of the different physical exam maneuvers in predicting heart failure. Now let's talk about the physical exam finding that probably has the best combination of strong positive likelihood ratio and strong negative likelihood ratio, and that's abdominojugular reflex. This is a physical exam maneuver in which you apply pressure to the right upper quadrant under the liver or the epigastrum and look for a concomitant sustained rise in the jugular venous pressure in the right internal jugular vein. You see when they press, the vein becomes more distended. When they let go, the vein flattens. This is a positive test for abdominojugular reflex. Positive likelihood ratio 8.0, negative likelihood ratio 0.3. Again, Dr. Mark Henderson.
So we're going to demonstrate abdominal jugular reflex here. And to do so, we need to apply a 20 to 30 millimeters of pressure to the abdomen, and we're going to use a blood pressure cuff to do that. So here what we do is we'll inflate the cuff a bit. And close it off. And place it here in the mid-epigastrium, and the amount of pressure that needs to be put is about there, 30 millimeters.
Using the blood pressure cuff is done to give you a feel for what 30 millimeters of mercury of pressure feels like, and only has to be done once or as many times as it takes you to get comfortable applying this degree of pressure to do the test.
So the idea here is to compress the abdominal vasculature, and we do that by putting our hand in the epigastrium. I usually place one hand over the other to put enough pressure to elicit an increase in the central venous pressure as I'm looking. So I'm pressing down, I hold this pressure for 10 seconds at least, and observe the neck veins. A positive sign is when the neck veins remain elevated for 10 seconds. A normal response or normal central venous pressure would be just a transient bump in the neck veins, which comes right back down.
I wanted to take a moment to point out here that the presence of jugular venous distension and one's overall clinical impression both have relatively strong positive likelihood ratios for predicting congestive heart failure in patients presenting to the ED, while the presence of RALS and lower extremity edema had lower positive likelihood ratios, meaning that they're still useful tests, but not as strongly predictive as some of the other physical exam maneuvers we've discussed today. Estimating the jugular venous pressure is an important skill and one that takes practice. Here, again, with some tips, is Dr. Henderson.
So when I think about examining a patient with heart failure, one of the most important parts of the exam is examining the central venous pressure. So what we're going to do is take a look at that and how to assess the central venous pressure. There are other parts of the exam. Of course, you never want to forget the general appearance of the patient, whether they're breathing in some kind of respiratory distress. We're going to do some pulses and other parts of the cardiovascular exam, but let's talk about the neck veins. So principally what you're trying to do by assessing the neck veins is estimate the central venous pressure. So the best way to do that is to identify the venous waveform of the internal jugular. So the jugular vein sits in a triangle that is bordered by the clavicle here and the two heads of the sternocleidomastoid. Remember, there are two bellies, one muscle belly that inserts here in the sternum, so that's the sternal head, and the other muscle belly inserts here in the clavicle, the clavicular head, forming a triangle like this. So the apex is here and the base is at the clavicle. Within that triangle, if you look at the medial portion, in other words, under the sternal head, is where the jugular vein lies. So what we're really looking for when we look for central venous pulsations is the reflection of the jugular vein under this muscle belly. So we're going to be looking right here in this region, right along this medial side of this triangle. So if we look again and inspect this triangle in the area that I was alluding to, what you're looking for is some type of pulsation or movement. As I inspect his neck over lateral to the clavicular head, I do see a pulsation. If you can see that there's a pulsation right there, which is apparent. That's the external jugular vein, which runs above here. Now is sort of a poor person's estimate of the central venous pressure, but it's not quite as accurate as the internal jugular. So that's really what we're looking for here. Now, I look in the triangle that I was alluding to here, I don't see any venous pulsations. So what I'm going to do in that case is I'm going to lower the head of his bed.
It's traditionally taught to position the patient leaning back at 30 to 45 degrees to perform this maneuver, but the correct angle is really whatever one will bring out the top of the jugular venous pulse in the right internal jugular. So most clinicians would start with the patient sitting straight up. If you can see the jugular venous pulse with the patient sitting upright, that's very telling. If you can't, then you begin to lay the patient back. And in the case of low central venous pressure, you may have to lay the patient back much more than just 30 degrees. In fact, you may have to lay them all the way supine before you can be able to see a jugular venous pulse to estimate their jugular venous pressure. One important distinction is being able to tell the jugular venous pulse apart from the arterial pulse found in the carotid artery in the same region. There are three key distinguishing features. One is the waveform. The jugular venous waveform is biphasic, corresponding to the atrial contraction during diastole and maximal atrial filling. Second, the meniscus at the top of the jugular venous pulse varies with the patient's respiration. So as they take a deep breath in, you'll see the top of the jugular venous pulse drop. Third, the jugular venous pulse, unlike the arterial pulse in the carotid, is not palpable. So if you put your finger over it, you won't be able to palpate a pulse like you would be able to with a carotid artery. Another useful pearl here is about lighting. Your lighting when you're doing this exam should always be tangential, that is, at an angle rather than head-on, because this allows you to use the bedsheet to help you assess for the jugular venous pulsation. Here you can see the shadow of our patient's jugular vein on the bedsheet and see how it varies in the same biphasic waveform as, in this case, his external jugular vein. You can use this to help not only find the jugular venous pulsation, but also to assess the height of the jugular venous pulse above the level of the right atrium. So let's take a look at McGee's evidence-based physical diagnosis calculator to take a look at some of these physical exam findings. So we select congestive heart failure from the drop-down menu, and let's set our pretest probability at 50%, based on that study I mentioned at the beginning of the video that found that around 50% of undifferentiated adults presenting to the ED with dyspnea had systolic heart failure. So we walk into the room and we look for jugular venous distension, which had a positive likelihood ratio of around 5. So that takes our post-test probability from 50% to over 80%, significantly making it more likely that this patient is in heart failure exacerbation. Now, the next physical exam maneuver we do is to test for abdominojugular reflux. As we saw earlier in the video, that has a positive likelihood ratio of over 8. So now, we're at around 90% certain if we have a positive exam finding there. Remember, I mentioned that abdominojugular reflux also had a pretty good negative likelihood ratio of around 0.3. So if we look for abdominojugular reflux and we don't see that sign, then that takes our post-test probability down to around 20% from 50%. That significantly changes our thinking. Finally, remember I said that the presence of an S3 on cardiac exam, if you can find it, is very predictive of systolic dysfunction. It takes our post-test probability up to 90% from a pre-test probability of 50%. Remember, that's also an independent predictor of increased mortality, surgical complications, elevated BNP, etc. Finally, initial clinical gestalt, which has a positive likelihood ratio of over 4, significantly changing your post-test probability, and a negative likelihood ratio of around 0.4, which again has a significant impact on your post-test probability, bringing it from 50 to less than 30%. So to conclude, let's review 4 take-home pearls from this video. The first is that pretest probability is uniquely important in assessing heart failure due to the fact that it has been so well studied in the literature. Second is that anytime you're evaluating a patient for left heart failure, you should look for jugular venous distension and check the abdominojugular reflux. These are easy and high-yield exam maneuvers that are not only predictive of right heart failure, but as the evidence shows, also very predictive of left heart failure. Number 3, learn to be excellent in your cardiac auscultation skills. So the practice that you could put in detecting subtle findings like an S3 will go a long way in helping not only with diagnostic information, but also with prognostic information in patients with suspected heart failure.
I think that, again, to review, the location of the PMI, if you don't find the apex beat, you'll never be able to hear an S3. You'll be listening to the wrong spot, and it's a very narrowly radiating heart sound. The second thing is, if you don't know how to use your bell with light pressure.
As Dr. Henderson says, learning how to accurately locate the point of maximal impulse and learning how to appropriately use your stethoscope using the bell in a quiet room with light pressure, it is difficult to locate this heart sound that can be very critical in diagnosing and prognosticating congestive heart failure. Finally, don't ignore your overall clinical gestalt. It is a moderately powerful predictive tool in its own right, with both a strong positive likelihood ratio and a strong negative likelihood ratio.